A very good evening to all of you. We are back with almost the last topic in this chapter of rheumatology. So it is vasculitis. So it's quite a huge topic. And if you keep reading like each and every disease separately, then you might end up getting confused and being in a big mess. So how I would like to approach this vasculitis is teaching you the approach towards vasculitis so that you don't miss anything. You will be able to tell how to actually identify a patient with vasculitis and how do you in general identify and then diagnose and then manage a patient with vasculitis. So this we are going to take it as an approach based topic. Okay, so let's start the approach to vasculitis. So let's begin with the introduction. What is vasculitis? What exactly is vasculitis? Itis is inflammation. We all know that. So vascular is inflammation of blood vessels, right? It's inflammation of blood vessels, which is characterized by leukocytic infiltration of the vessel walls. Mostly it's a neutrophilic infiltration of the vessel wall. Sometimes there can be macrophages infiltration also. So vasculitis is inflammation of blood vessels, right? Inflammation of blood vessels. Okay. So there are different patterns of vessel involvement in different entities. So there are many diseases which come under this category of vasculitis, and each pattern will show a different vessel involvement and each pattern shows a different pathology. So we will be usually classifying this based on the pathology as well as the vessel involved. Okay, we'll go through it in detail. So once the vessel lumen becomes compromised, what happens? There is ischemia to the corresponding organ and the features start becoming severe. Okay, it becomes severe vasculitis. So what happens? There is inflammation of the blood vessel because of leukocytic infiltration into the vessel walls. Okay, different vessels are involved, which shows different manifestations. Okay, let's move on. So first of all, based on the pathogenesis, first we'll discuss the pathogenesis. Based on that, how we classify, and then we go on to the vessel wall type. What kind of vessels are involved? That will be the next classification. So before we go into the pathogenesis, we need to know that three main important pathogenesis are active here. Okay, either of these can be active to actually cause the disease process. So there are three main important things. First is immune complex formation. The second one, it can be ANCA mediated. What is ANCA? Anti-neutrophilic cytoplasmic antibody mediated, right? And the next one is granuloma formation. Granuloma formation, which kind of cells are involved? T cells are involved, right? T cells are involved. So it is T lymphocyte mediated granuloma formation. So T lymphocyte mediated granuloma formation, we need to remember this very well. One is granuloma formation, next is ANCA mediated, next is immune complex mediated. So immune complex mediation means what kind of hypersensitivity reaction is it? It is type 3 hypersensitivity reaction, right? Type 3 hypersensitivity reaction, that's how it works, right? Okay, so let's now start with immune complex formation. Which are the diseases that come under immune complex formation? Okay, so there is an antigen, an antibody comes and gets attached. So an immune complex is formed, which goes and gets deposited in the vessel wall, which causes the inflammation, right? So this is an immune complex formation. That is the pathology behind that. So where all do you see this Henox condyline purpura? That is HSP. HSP, it is usually seen in kids. It can be seen in adults also, and it is IgA mediated, immunoglobulin A mediated. Okay, HSP is seen in adults as well as children, right? Adults as well as children. Next, SLE and other collagen vascular diseases. In that, ANA is the antigen, anti-nuclear antibody, antigen. Anti-nuclear antigen, that is what is involved. Then serum sickness. It can be even due to snake bite. That can also cause this immune complex formation, and then it can cause vasculitis, right? Polyarteritis nodosa because of hepatitis B infection. Hepatitis B infection, polyarteritis nodosa. Then because of hepatitis C infection, you can have cryoglobulinemia. All these are examples of immune complex formation. What is immune complex? An antigen is there, an antibody comes and gets attached to it. Then it forms an immune complex, goes and gets attached to the vessel wall where it causes an inflammatory reaction, right? So this is called immune complex formation, and these are the examples: HSP, which can be seen in adults as well as children, collagen vascular disorders and SLE, serum sickness, polyarteritis nodosa, hepatitis B antigen, essential mixed cryoglobulinemia, or hepatitis C infection also, right? Next, ANCA mediated. So, ANCA, there are two types, C ANCA and P ANCA, right? C ANCA and P ANCA. So, anti-neutrophilic cytoplasmic antibody. What is it? Anti-neutrophilic cytoplasmic antibody. Okay. So, in this, what is P ANCA? What is C ANCA? So, P ANCA is against which one? It is against MPO. What is MPO? It is myeloperoxidase. It is against myeloperoxidase. And C ANCA is against PR3. What is PR3? Proteinase 3. So, C ANCA is against proteinase 3 and P ANCA is against myeloperoxidase. Let me tell you an easy way to remember. P is here and P is here. So, you must remember, it's not that much one is starting with P. So, myeloperoxidase, P ANCA, MPO. C ANCA, PR3, proteinase 3. So, P ANCA is formed against the proteinase 3 antigen and P ANCA is formed against the myeloperoxidase antigen. So, what are the other ANCA associated vasculitis? You have Church-Strauss vasculitis. You have microscopic polyangiitis. What is Church-Strauss vasculitis otherwise called? It is now called as EGPA. Eosinophilic granulomatous polyangiitis. Eosinophilic granulomatous polyangiitis. Microscopic polyangiitis and vaginous granulomatosis, that is also called as granulomatosis polyangiitis. So in vaginous, you have granulomatous polyangiitis. This is the same as what we have in Church-Strauss. Plus, you have a component of eosinophilia, right? In Church-Strauss, you have eosinophilia. It's called eosinophilic granulomatous polyangiitis. Whereas in vaginous, it is called granulomatous polyangiitis. I want you to know both the terms. That's why I've written it in the older format so that I can tell you the newer words. Okay. Yes. So what happens here? There is aberrant expression of this proteinase 3 and MPO over the surface of the neutrophils, because of which antibodies are coming and getting formed. These are ANCA antibodies. This causes the destruction of the neutrophils and the vessel wall becomes damaged. Right? So this is how the ANCA pathology works. This is called anti-neutrophilic cytoplasmic antibody. Right. So this is just a picture explaining. So you have a neutrophil type of blood cell. On this, the MPO and PR3 are getting expressed. So what happens? The ANCA comes and gets attached to this. And what happens? Then there is inflammation of the vessel wall. Vasculitis happens. This causes vasculitis. This causes vasculitis. Yes? Yes. So next move on to the third pathology, which is granuloma formation. This is T lymphocyte mediated formation. T lymphocyte mediated formation. So among this, what are the types of vessel involvement that you have? You have giant cell arteritis. It is also called temporal arteritis, giant cell arteritis, or temporal arteritis. You have Takayasu arteritis. You have vaginous granulomatosis, also called you saw that, right? There is granulomatous polyangiitis. This is called granulomatous polyangiitis. So this is granulomatous polyangiitis. Granuloma is there. So in this, you can see that there are two mechanisms which are working. One is ANCA mediated, and the other one is granuloma formation also, right? And Church-Strauss vasculitis, EGPA, eosinophilic granulomatous polyangiitis, right? So what happens in this? There is a classical granuloma formation. Giant cells will be there. Epithelioid cells will be surrounding that, and there will be fibrinoid necrosis, right? There will be fibrinoid necrosis in the center. Caseous necrosis means it is tuberculosis. If it is fibrinoid necrosis, you can see in this granuloma, which is in vasculitis. So you need to remember the type of necrosis in this is fibrinoid necrosis, right? Fibrinoid necrosis. This one you need to remember very, very clearly. Okay, how will you find this out? You have to do a vessel biopsy to find this out. Okay, so you have seen what is mediated by immune complex formation. Next you saw ANCA mediated. Next you saw granuloma formation. Right, now let's move on. So coming to the approach to vasculitis. Yes, how do you approach? So there are a few steps, around 5 to 6 steps are there. Like how you approach vasculitis, we'll go step by step. Right, so first is the first step. So how to recognize vasculitis? How do you even consider the diagnosis of vasculitis in a patient? Okay, so before that, you need to know that there are some common features of vasculitis. There are some common features of vasculitis, but most of the vasculitis will have one feature, which is constitutional symptoms. Okay, constitutional constitutional symptoms, right? All vasculitis will definitely have constitutional symptoms. This is very, very important. They will have it in varying degrees. Some diseases might have a lot of constitutional symptoms, but some diseases might have in a lesser degree. But definitely constitutional symptoms like fever, myalgia, tiredness, excessive fatigue, all these are common features of vasculitis. So this is very, very important. In all the rheumatological conditions, almost all the rheumatological conditions, take it rheumatoid arthritis or SLE, or any of this, even vasculitis, you have definitely constitutional symptoms. Okay. Apart from that, well, it is also multisystemic, right? It is also multi-system. It is not just one system which is involved, right? It is multi-system. So you will have skin getting involved, you will have renal getting involved, you will have the pulmonary capillaries getting involved, pulmonary vessels getting involved, you will have the nerves getting involved, you have all the systems which are getting involved, and based on what disease it is, different systems will get involved. So when the cutaneous, that is the skin, is getting involved, you will have palpable purpura. You can have ulcers, right? You can have ulcers, you can have purpuric lesions. When the pulmonary system is involved, you can have pulmonary infiltrates, right? If the capillaries are involved, you will have pulmonary infiltrates, or you can have cavitating lesions. You can have so many different things when the pulmonary system is involved. The kidney can also be involved when you will have microscopic hematuria, right? Kidney can also be involved, and you can have glomerulonephritis, microscopic hematuria, as well as proteinuria also. Proteinuria as well as microscopic hematuria. When the nerves are getting involved, when the vessels in the nerves are getting involved, you will have mononeuritis multiplex. And you can also have some unexplained ischemic events like Raynaud's phenomenon, digital gangrene, mesenteric ischemia. You can also have a stroke or an MI. All these vascular complications can also happen. Okay, it necessarily not always be an atherosclerotic disease. Vasculitis can also cause all these symptoms. You need to know. So it is varied presentation that you must remember. But constitutional symptoms, you need to remember that constitutional symptoms will definitely be there, and it will be a multi-system involvement mostly. Okay, it will be a multi-system involvement. Right? Let's move on. So these are some photos. Palpable purpura. This will be palpable. It will usually be not itchy. Non-itchy, palpable purpura. These are erythematous. Palpable purpura. So you can see the pulmonary infiltrates. This is usually seen in diffuse alveolar hemorrhage. Diffuse alveolar hemorrhage seen in different vasculitis presentations. Okay. So this is diffuse alveolar hemorrhage. Right? Yes. Next is microscopic hematuria. Along with this, what did I tell you? You can also have proteinuria. You can also have proteinuria. Right? Yes. So next, moving on to the second step. So what was the first step? You need to think whether this patient can have vasculitis. That is the first step. So second step is you need to rule out the secondary causes of vasculitis. So apart from the patient having a primary vasculitis, there are some other causes of vasculitis like malignancy, like drugs. All these things can also precipitate a patient to have vasculitis. So this you must remember. So what are the secondary causes of vasculitis? You need to rule this out before telling that the patient is having a primary vasculitis. This is very, very important, right? Rheumatological manifestation may be a presentation of an infection, right? But you should not treat that as a vasculitis. You must treat the primary infection first, then only this will get cured. Okay, so you need to remember that in mind. So what are the secondary causes of vasculitis? First is infections. Among that, the most common is endocarditis, right? Among that, the most common is endocarditis. The other most important one is Lyme's disease, right? Lyme's disease. Then the other one which is important is gonococcal infections, right? Gonococcal infection. Endocarditis is most common, which can present as vasculitis. You can see splinter hemorrhages, right? You can have some vasculitic, you can have some immunological phenomena, right? You have listened to that in the class of endocarditis, infective endocarditis. So apply that here. So endocarditis can present like symptoms of vasculitis, Lyme's disease, and gonococcal infection. Moving on to malignancies, among that the most important one will be atrial myxomas. Atrial myxomas. Among that the most important one will be atrial myxomas. Also, what are more important? Lymphoma. Okay, what is most important? Lymphomas also. Atrial myxomas or lymphomas also present as vasculitis. So next, moving on to the thrombotic microangiopathies. What is it? HUS and TTP. Hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. Okay, HUS and TTP. So moving on to the drugs, what are the important drugs which can present as vasculitis features? So you have cocaine, right? Phenytoin, sulfa drugs. Okay, you have cocaine, phenytoin, sulfa drugs, propyl thiouracil, etc. Propyl thiouracil, etc. So all these can also cause features like vasculitis, right? Cocaine, phenytoin, sulfa drugs, propyl thiouracil. There's a huge list. But few things you must remember definitely. Cocaine, phenytoin, sulfa drugs, propyl thiouracil. Among the others, what are the secondary causes of vasculitis? You can have SLE. You can have rheumatoid arthritis. SLE, rheumatoid arthritis. You can have atheroembolic disease. Atheroembolic disease. In that, you will see that the patient is having livedo reticularis. The patient can have emboli, right? Infarction can be there, which can present like vasculitis. So all these are very, very important. You definitely need to rule out the secondary causes of vasculitis. So infections, malignancies, thrombotic microangiopathies, drugs, and others. Okay, drugs and others. Sometimes even you can see in ICUs, they would be giving an inotropic infusion, like say noradrenaline, and the patient will have digital ischemia. Okay, distal digital ischemia can be there. That is because of the effect of the vasopressors. That you might think that it is vasculitis. So this is a secondary cause of vasculitis. So noradrenaline infusion can also cause peripheral digital ischemia. So in those patients, you should not think that it is vasculitis. You need to rule out the secondary cause. So the secondary cause in that situation is noradrenaline infusion. Okay, so this is very, very important that you rule out the secondary causes. So now moving on to the step 3. You can now see how simple it is, right? So step 3, this is the most important one. This is another type of classifying vasculitis also. So what is the pattern of vessel involvement? What is the pattern of vessel involvement? Is it a large vessel? It is a medium vessel, or is it a small vessel vasculitis? Okay. So based on this, you will be able to identify the symptoms also, right? So based on this, you will be able to identify the symptoms also. So let's go through it. So it can be either large, it can be medium, or small vessel vasculitis, right? It can be small vessel vasculitis. Among that large vasculitis, you have first one is giant cell arteritis or temporal arteritis. The second one will be Takayasu arteritis. Takayasu arteritis. Among the medium vessel, you will have first one will be polyarteritis nodosa, polyarteritis nodosa, and the next one will be Kawasaki disease. Kawasaki disease. So among the small vessel vasculitis, you have to classify it whether it is ANCA associated or it is immune complex associated, right? Whether it is ANCA associated or it is immune complex associated. If it is ANCA associated, in that what will happen? The immune complexes are not much formed. So it is pauci-immune. It is called pauci-immune. Pauci-immune. There is not much of immune complex deposition in the vessels. So it is called pauci-immune. Among this, what you have? You have granulomatosis polyangiitis, that is vaginous, eosinophilic granulomatous polyangiitis, which is Churg-Strauss. Yes, then you have microscopic polyangiitis. Microscopic polyangiitis. Right. Among the immune complex deposition ones, you have HSP. You have cryoglobulinemia. Cryoglobulinemia. And the third one will be SLE or other connective tissue disorders. Okay, SLE or other connective tissue disorders. So among the large vessel, you have giant cell arteritis, you have Takayasu arteritis. Among the medial vessel, you have polyarteritis nodosa and Kawasaki disease. Among the small vessels, you have either ANCA involvement or immune complex involvement. If it is an ANCA involvement, it is called pauci-immune, and in that you have granulomatous polyangiitis, eosinophilic granulomatous polyangiitis, or microscopic polyangiitis. Among the immune complex ones, you have HSP, cryoglobulinemia. HSP is also IgA vasculitis, and you will have SLE or other connective tissue disorders which are involved. So you have an idea about what is large vessel, medium vessel, and small vessel, right? Yes. So let's see a picture for you to remember even better. So aorta, if the aorta is involved, or if a large to medium sized large artery is involved, then you have giant cell or temporal arteritis. Sorry, you have a giant cell or temporal arteritis. Giant cell or temporal arteritis and Takayasu arteritis also. So moving on to the medium sized artery, you have polyarteritis nodosa and Kawasaki disease. So when it goes on to the small artery, you have Vigenous granulomatosis and Church-Strauss syndrome, which is EGPA, GPA and EGPA, right? And you also have microscopic polyangiitis. Even smaller vessels, then you have henox-condyline purpura and cryoglobulinemia. When the capillaries are involved, you have cutaneous leukocytoclastic angiitis. Okay. So you now see from large vessel, medium vessel and small vessels. All these are getting involved in a sequential manner. Based on which vessel is involved, you will have such symptoms which the patient is presenting. So this large vessel may not present with glomerulonephritis. Okay. If suppose you have a patient with Takayasu arteritis, the renal arteries can be involved. They will have renovascular hypertension, but the patient will not have glomerulonephritis because the capillaries are not involved. Okay, only when the capillaries are involved, you will have glomerulonephritis in that patient. Like henox-condyline purpura, the patient will have IgA vasculitis. So in that, the patient can have IgA glomerulonephritis. Okay, so this is very, very important that you need to remember. Based on what artery is involved, what size of artery is involved, the manifestations will be presented. Okay, yes. So now moving on to that, you need to think of other primary vasculitis also, which are either single vessel or their variable vessel presentation. Okay, they can either be a single vessel presentation or variable presentation. Okay, single vessel presentation or a variable presentation can be there. So you need to remember thromboangiitis obliterans. These are other vasculitis that you need to remember. The thromboangiitis obliterans, Behçet's disease, idiopathic cutaneous vasculitis, isolated vasculitis of CNS. This is a single vessel vasculitis. Isolated CNS vasculitis, then relapsing polychondritis and polyangiitis overlap syndrome. This you have features of more than one type of vasculitis. Okay, so apart from the vessels which are involved, large vessels, medium vessel and small vessel, you can also have a single vessel presentation or a variable vessel presentation also, right? So this is very important for you to remember. So we finished 3 steps. First, you need to have the suspicion of having a vasculitis in this patient. You need to know when to be suspicious of vasculitis in that patient. Then you have to rule out the secondary causes of vasculitis. Then you need to know the vessels which are involved. And then coming to the step 4, we need to learn the characteristic presentation of each vasculitis. In this, I'm going to tell you some salient features for each vasculitis. So if initially I had taken all this, then you would not be able to correlate easily. Okay. So that's why we are taking it in the middle of this so that you're able to understand better. Okay. So let us now see the characteristic presentation of each vasculitis. So giant cell arteritis. It is also called temporal arteritis, right? It is also called temporal arteritis. And it is a disease of the elderly. It is a disease of the elderly, usually seen in more than 50 years of age. More than 50 years of age. Are females involved more or males involved more? It is more common among females. It is more common among females, you need to remember. So, this patient will have non-specific symptoms, but the most characteristic symptom will be a severe headache. A severe headache, right? A severe headache will be there. So, when you see what will happen, you can see that there is a prominent temporal artery. Okay, the temporal artery will be very prominent with decreased pulsations. You will have a temporal artery which is prominent but with decreased pulsation. The patient will have a severe headache. Okay, severe headache. And the patient will have an elevated ESR. You must have remembered this. ESR is characteristically more than 100 millimeters. Right? ESR is characteristically more than 100 millimeters. In all cases of inflammation, especially in vasculitis, you will find that the ESR is elevated. But in patients with giant cell arteritis, what will happen is the ESR will characteristically be more than 100 millimeters. Right? So you see that the first presentation, non-specific symptoms, constitutional symptoms will be there. Then you will have headache. What is the other presentation? The patient can have polymyalgia rheumatica. What is polymyalgia rheumatica? The patient will have pain here, pain there. The patient will have pain all over the body, right? The patient will have pain, inflammatory pain all over the body with stiffness, especially involving the shoulder and pelvic girdle, right? Shoulder and pelvic girdle. shoulder and pelvic girdle will be involved. Polymyalgia rheumatica, they will have inflammatory pain and stiffness in the joints. Shoulder and pelvic girdle will be involved very commonly. So what is the other complication? You will have blindness. Presentation will be blindness. So usually the blindness can be unilateral or bilateral. It can be temporary or permanent. But the most common one will be, it will be unilateral plus a temporary deficit. Unilateral plus temporary deficit, right? And the patient can also have jaw claudication, scalp pain, and scalp tenderness. Okay. So it is also called temporal arteritis. The patient have non-specific symptoms. Headache will be the most common presentation, and the patient can have also can have polymyalgia rheumatica, which is inflammatory pain in the shoulder, pelvic girdle, and other joints. Then the patient can have blindness, usually unilateral and temporary. The patient can have jaw claudication, scalp pain, and scalp tenderness. Blindness is the most common dreaded complication. It is most serious complication, right? You must remember that. Okay. So which is the more common artery which is involved? Most commonly involved artery is superficial temporal artery. Superficial temporal artery. Superficial temporal artery. So if the patient is having ophthalmoplegia and jaw claudication, then that means that the patient is definitely having giant cell arteritis. It has a 100% positive predictive value for diagnosing giant cell arteritis in this patient. Okay. So this is very, very important. So the patient will have giant cell arteritis. A superficial temporal artery is getting involved. There will be a nodular artery. So you can see here, there is a nodular artery in a patient with giant cell arteritis. There is a nodular artery in a patient with giant cell arteritis, and the pulsations will be decreased. Decreased pulsations. The pulsations will be decreased. Right? Pulsations will be decreased. Yes. So next, moving on to Takayasu arteritis. Takayasu arteritis, it is again one more disease that you have already discussed. I mean, we have studied in one thing, which is female is to male presentation will be 9:1. What are the other diseases? The other diseases are SLE, Sjogren's, and primary biliary cirrhosis with 9:1 presentation. More common in the females. Right? So Takayasu arteritis, SLE, Sjogren's, and primary biliary cirrhosis. So Takayasu arteritis is also called a pulseless disease. Why is it called a pulseless disease? Because Takayasu arteritis usually manifests as stenotic lesions. There is stenosis. So what happens because of that? You will have decreased pulsations. This characteristically, you will see that the patient is having different BPs, differential BP in the upper limbs. Okay, one hand will show normal BP, one hand will show lesser BP. Okay, so this is Takayasu arteritis. It is more common among females. I told you middle-aged females, more than 40 years. It will be around 40 years. The patient will be around 40 years. And the arteries which are involved are aorta. It is a large vessel vasculitis. So aorta and its branches are involved. The renal artery can also be involved when the patient will have renal artery stenosis. But the most common artery which is involved is subclavian artery. Most common artery which is involved is subclavian artery. In giant cell arteritis, the most common artery which is involved is superficial temporal artery. Whereas in Takayasu arteritis, it is subclavian artery. The aorta and its branches will be involved. So what are the other vessels which can be involved? Carotid vessels, mesenteric vessels, as well as the renal artery can be involved. And this patient will chronically have a relapsing course. So you give the treatment and the patient will be fine for some time, then the patient will again have a relapse. So this is very, very common. So in patients with Takayasu arteritis, what happens? Even the heart can be involved, right? Even the heart can be involved. And the most common presentation is aortic regurgitation. And the most common presentation in the heart will be aortic regurgitation. Okay, you need to remember Takayasu arteritis more common in females, 9:1. The most common artery involved is subclavian artery. The large vessels are involved, subclavian vessels, carotid vessels, mesenteric vessels, renal vessels. Right, it is called a pulseless disease. The BP is unequal and the pulse will also be unequal. It is usually seen in middle-aged females. Right? Yes. You can see the stenosis here. Okay, you can see the stenosis here. Yes. So next one is polyarteritis nodosa. So we are now moving on to the medium vessel vasculitis, which is first one is polyarteritis nodosa. Polyarteritis nodosa is usually seen in the 4th to 6th decade. Where is it seen? 4th to 6th decade. You will characteristically have a patient in his 50s coming to you with these symptoms. In this, what happens? The pulmonary and the renal component is most common. They will have pulmonary manifestations as well as renal manifestations in these patients. And one word you must remember about polyarteritis nodosa is the development of microaneurysms. Microaneurysms. This is a key word that you must remember about microaneurysms, about polyarteritis nodosa, that is microaneurysms, right? These patients usually have a very, very poor prognosis. Polyarteritis nodosa, the prognosis is very poor prognosis, because these patients are steroid refractory. They do not respond to steroids. Okay, so this is steroid refractory. So the prognosis is very, very poor. Polyarteritis nodosa, they are steroid refractory and the prognosis is very, very poor. So the renal arteries will be involved, which causes renovascular hypertension. The pulmonary vessels are not involved. Okay, pulmonary vessels will not be involved. Then what is this associated with the patients of hepatitis B infection? We saw it initially. Infections will be there, then the patient can have vasculitis. So hepatitis B and hairy cell leukemia are two common presentations. Yes, hepatitis B and hairy cell leukemia are two very, very common presentations, right? And the most characteristic thing that you need to remember is microaneurysms. Microaneurysms you need to remember. And hepatitis B is another thing that you must remember about polyarteritis nodosa. And it's a poor prognosis lesion, poor prognosis disease, right? Yes. Next is Kawasaki vasculitis or Kawasaki disease. It is seen always in children. It is a disease of the children, right? It is always a disease of the children, usually less than 5 years. It can be even seen in children between 5 to 10 years. Okay. What is it otherwise called? It is called mucocutaneous lymph node syndrome. What is it called? It's called a mucocutaneous lymph node syndrome. Because the skin can be involved, the mucous membranes can be involved, like the oral lesions, genital lesions can be there, right? So this is called a mucocutaneous lymph node syndrome. What do you see in this? In these patients, you will have erythematous lesions over the skin, right? Erythematous lesions over the skin. And also mucous membrane. You will have some aphthous ulcers also. And cervical lymphadenopathy will be there. So you will have desquamatus erythematous lesions involving the skin, mucous membrane, and the cervical lymph nodes. And what is the most dreaded complication in this patient? They will have coronary aneurysms, right? They will have coronary aneurysms. So what happens in these patients? Usually there are three phases. First is a febrile phase. Then next will be a vasculitic phase. And next will be a convalescent phase. Convalescence is where the patient will be improving. Convalescence is where the patient will be improving. So the febrile phase will be usually for around 10 days. Then vasculitic phase will be for around another 10 days. And the patient will be going into convalescence after that. Right. During the convalescence, what will happen? These coronary aneurysms will form. These coronary aneurysms will be forming. Okay. And it is a dreaded complication. The patient can die because of these. Okay. So it is a very, very drastic disease which needs to be treated immediately. Okay. Let us see some pictures of this Kawasaki disease. All of you must be knowing this. Yes. What is this? This is strawberry tongue. This is strawberry tongue. Yes. Next one, what will happen? The palms and the soles, palms and the feet will get inflamed. They will get swollen and erythematous. They will be swollen and red, erythematous, right? In the eyes, what you will have? You will have congestion. Corneal congestion will be there, right? And what happens to the feet? And all over the body, you will have erythematous rashes. Erythematous rashes will be there. Okay, so these are some of the features of Kawasaki disease. You will have congestion in the eyes, you will have swollen erythematous palms and soles, you will have a strawberry tongue, and you will have erythematous rashes all over the body, especially over the trunk. Okay, so this is Kawasaki disease. Next is pauci-immune vasculitis. In these patients, we already saw pauci-immune is there is not much of immune deposits. There is no immune complex deposition. Right. So pauci-immune deposits are not there. Pauci-immune means there is not much of vasculitis deposits. Pauci-immune, we don't have much of immune complex deposition. So that's called pauci-immune vasculitis. In this, you will have pulmonary capillaritis plus glomerulonephritis. So we now moved on to the small vessel vasculitis. Right. We saw medium vessel polyarteritis nodosa and Kawasaki disease. We have now moved on to the small vessel vasculitis. In that, you have pulmonary capillaritis and glomerulonephritis. I told you, when the small vessels are involved, you will have glomerulonephritis, which is characterized by hematuria, proteinuria, and you will have edema, hypertension. All these can be there in these patients, right? So in this, there are three important topics which are there. So when the patient is having a granuloma plus asthma plus eosinophilia, this is eosinophilia, that is Church-Strauss or EGPA. When the patient is having granulomas with no asthma but an LRTI and upper respiratory involvement, you will have vaginous, which is GPA. Right? When there is no granuloma, no asthma, you will have microscopic polyangiitis. Microscopic polyangiitis. Right? Microscopic polyangiitis will be seen in these patients. Okay. So what is vaginous granulomatosis? What is this called? And you need to keep revising this because this is the latest terminology that is there. So granulomatous polyangiitis. In this granulomatous polyangiitis, we know that there is polyangiitis, small vessels are involved, it is pauci-immune, and granuloma formation will be there. So now I told you one more thing. You will have upper respiratory involvement plus lower respiratory involvement plus renal involvement. Upper respiratory involvement plus lower respiratory involvement plus renal involvement. So for the upper respiratory involvement, upper respiratory and lower respiratory involvement, what will you have? Upper respiratory, you can have chronic sinusitis. The patient will have sinusitis. For the lower respiratory involvement, you will have pulmonary nodules, pulmonary cavities, and for the renal involvement, you will have glomerulonephritis, which will be rapidly progressing. It is called RPGN, rapidly progressing glomerulonephritis. That will be there. So the patient can also have some, apart from all these upper respiratory, lower respiratory, and renal involvement, the patient can also have cutaneous lesions. The patient can also have some ocular lesions, right? In these patients, non-specific symptoms will be there. So it's very difficult for you to identify that the patient is having vaginous granulomatosis. The patient could have had an upper respiratory involvement and then developed a lower respiratory involvement, and then you can have a presentation of renal involvement. It's not necessary that all should happen at the same time. They will be happening immediately, one after the other, or at the same time also. But you must be very keen on identifying these patients. So non-specific symptoms will be there in these patients, right? So what will you see in these patients? So you see, I told you there is a cavity. These are called cavitating nodules. Cavitating nodules. These are characteristic findings. In vaginous granulomatosis, GPA, you have cavitating nodules. Here also you can see the cavitating nodules, right? These are characteristic findings. Cavitating nodules will be there. So these patients can also present with hemoptysis when there is capillaries involvement in the lungs. That is diffuse alveolar hemorrhage. If the patient is having diffuse alveolar hemorrhage, like we saw the first X-ray where you saw some dot hemorrhages, then we have diffuse alveolar hemorrhage, the patient can present with hemoptysis. Okay, you need to keep this presentation also in mind. Okay, so you have cavitating nodules, right? So moving on to Church-Strauss vasculitis. The Church-Strauss vasculitis is also called EGPA, right? Eosinophilic granulomatous polyangiitis. So the patient will have asthma, eosinophilia, and pulmonary infiltrates along with glomerulonephritis. Along with glomerulonephritis. You need to remember this. The patient will have asthma, eosinophilia, and pulmonary infiltrates along with glomerulonephritis. And in this, what is the most common cause of death? That will be myocardial involvement. This EGPA, what happens, Again, this has three phases. Where else did we see these three phases? We saw it in Kawasaki disease, febrile phase, vasculitic phase, and convalescent phase. What happens in this vasculitis, Church-Strauss vasculitis or EGPA? What happens? Again, there is a prodromal phase. Then what you have? You have a pulmonary phase, right? And the third one will be a vasculitic phase, right? Pulmonary phase and vasculitic phase. So in prodrome, what will you have? You will have asthma-like symptoms. You will have asthma-like symptoms. In pulmonary phase, what you will have? You will have eosinophilia with pulmonary infiltrates. In the vasculitic phase, what you will have? You will have eosinophilic gastritis, right? Eosinophilic myocarditis. All these things will be developing, okay? And the patient can end up in death because of myocardial involvement. When the myocarditis is causing, then you can have death in these patients, right? You need to remember this. So three phases, prodrome, pulmonary phase, and vasculitic phase will be there, right? Yes. Next, move on to the microscopic polyangiitis, which is the last Small vessel vasculitis. Microscopic polyangiitis. In this, what will you have? You will have pulmonary alveolar capillaritis and glomerulonephritis. No granuloma formation, right? No granuloma, no asthma. No granuloma, no asthma. You will have pulmonary alveolar infiltrates as well as glomerulonephritis in these patients. Yes. So next move on to the henox spondyline purpura. This is immune complex mediated, right? This is immune complex mediated, which is the most common immunoglobulin involved. It is IgA. IgA is involved, right? IgA is involved. This can be seen in both children and adults. Children and adults, right? Children and adults. What happens in this? You can have it usually presents in the second decade when it presents in the adults. Okay, whereas it can also present in the children, right? So what all are involved in these patients? You can have skin. When the skin is involved, you will have palpable purpura. We saw the picture first itself. It is palpable purpura over the limbs. Then the GI can be involved. So what will the patient have? The patient will have abdominal angina. The patient will have abdominal angina, right? Abdominal angina will be for the patient. Then the patient can have fever and polyarthralgia, which are constitutional symptoms. Constitutional symptoms, right? But what happens when the renal is involved? What are the renal manifestations? The patient can have hematuria. It can either be macroscopic or microscopic hematuria, which usually develop to ESRD in around 5% of the cases. In around 5% of the cases, the patient can go in for end-stage renal disease. Okay, the patient can go in for end-stage renal disease, right? So the patient can present with hematuria, which can progress to end-stage renal disease, right? So the patient can also have joint involvement. See, I told you joint involvement will be there. The patient will have difficulty in walking also. So we have seen now the skin involvement, palpable purpura. When the GI system is involved, the patient can have abdominal angina, bowel ischemia can be there. Intussusception can also be caused, which is the most common complication. Intussusception can be there. When the renal system is involved, you will have hematuria, which can actually progress to ESRD in around 5% of patients. And the patient can also have constitutional symptoms and joint involvement. Okay. So what do you see in this patient? I told you IgA will be elevated, right? IgA will be elevated. Right, IgA will be elevated, increased IgA levels in the blood. Okay. So next is, you will see some pictures. You can see here the palpable purpura, right? Palpable purpura will be there. And on microscopy, we'll see what will happen, what we can see in the microscopy, we'll discuss further. Okay, so this is henox spondyline purpura. You will have IgA deposits on immunofluorescence. IgA deposits on immunofluorescence under the microscope. Right. Next is cryoglobulinemia. I told you hepatitis B infection is associated with polyarteritis nodosa. These are, dictums that you must remember. Hepatitis B infection, polyarteritis nodosa. Hepatitis C infection, cryoglobulinemia. Okay, cryoglobulinemia. These cryoglobulins are usually of 3 types. Okay, cryoglobulins are usually of 3 types. Right? So the first type, where do you see it? In plasma cell disorders. Plasma cell disorders. So what is plasma cell disorders? Usually multiple myeloma, Waldenstrom's macroglobulinemia, In all these patients, you can have type 1 cryoglobulinemia, right? So going on to type 2. Where do you find this type 2? This thing. That is essential mixed cryoglobulinemia. Where do you see it? You see it associated with SLE or Sjogren's. SLE or Sjogren's. Also in hepatitis C, right? Hepatitis C involvement. Essential mixed cryoglobulinemia is seen in SLE or Sjogren's. It is also seen in hepatitis C infection. Type 1 plasma cell disorders. Type 2 essential microglobulinemia. Essential mixed cryoglobulinemia. In that, you can see it in hepatitis C patients also. And type 3. Where do you see type 3? You can see in similar kind of patients in other connective tissue disorders. But type 2, you must remember, it is seen in hepatitis C infection. Type 2 hepatitis C infection. So what happens in this patient? They can have pulmonary manifestation, renal manifestation, or cutaneous vasculitis can be there. So in which age group do you see this? It is usually around 40 to 60 years and more common in females. It is usually seen in 40 to 60 years and it is more common in females. So the pulmonary manifestations can be there, renal manifestations and cutaneous vasculitis can be there. So when the renal involvement is there, you can have MPGN, membranoproliferative glomerulonephritis type 1. Type 1, that will be the histology on the microscope, under the microscope. So pulmonary involvement, renal involvement and cutaneous vasculitis. Okay, what are the other associations? That can be thromboangiitis obliterans. Chronic heavy smokers can cause cryoglobulinemia. There will be infiltration of the arteries, veins, as well as nerves. When the nerves are involved, you will have mononeuritis multiplex. You can have upper limb and lower limb gangrene. There will be claudication. There will be ulcers which are not getting healed at all. Right? These can all be there. So what is the triad of cryoglobulinemia? What is the triad? You have triad will be arthralgia, right? Arthralgia, purpura, and myalgia. The triad will be arthralgia, purpura, and myalgia. All these three will be there in essential mixed cryoglobulinemia. Type 2 cryoglobulins, hepatitis C infection. Pulmonary involvement, renal will be MPGN 1. Then cutaneous vasculitis will be there. So gangrene can be there. You can also have ulcers which are not at all healing for a long time. Okay, these are very, very important for you to remember. Okay, so there are some other primary vasculitis which I told you which have a variable presentation, or they can be a single vessel involvement. Among that, you have Behçet's disease. You have idiopathic cutaneous vasculitis, isolated vasculitis of the CNS. You have relapsing polychondritis, polyangiitis overlap syndromes. Polyangiitis overlap syndromes. Right? Yes. So let's see a little bit about Behçet's disease. Behçet's disease, you need to remember some few important points. What is this HLA association? HLA-B51. Right? HLA-B51. This is very, very important. It is very, very commonly asked in your MCQs. So HLA-B51 is the association. In this, what all do you find? You have ulcers. After ulcers, oral ulcers. You will have uveitis. You have uveitis, ulcers, uveitis. You will have genital ulcers. You will have genital ulcers, both male and female. Right? You will have genital ulcers. This will be anal ulcers, perianal ulcers. Right? So you will have oral ulcers. You will have uveitis. You will have genital ulcers and perianal ulcers. Okay? So all these things will be there. So there is something which is very, very important. Like I told you, in all the diseases, I'm telling you the important points which you must know before going for the exam. Right? These are must-know points. So in this, pathology test is very, very important. What happens? This is a skin infiltration test, right? This is to prove that the patient is having Behçet's disease. What happens? They will inject something over the saline into the intradermal space, right? And the lesion is read after 24 to 48 hours, like we see in Mantoux test. What happens? There will be a papule or a pustular lesion with erythema on the injection site. You can see there will be papule or pustular lesion in that place on the injection site. When this becomes positive, then this is called a pathology test. Positive. Pathology test positive. Positive indicates Behçet's disease. Behçet's disease, right? Behçet's disease. Right. So pathology test, this is very, very important. And two syndromes that you must remember and very commonly asked, and you can also find it in your clinical practice. One thing is sweet syndrome and another one is magic syndrome. Right? Sweet syndrome is when the patient is having acute febrile painful neutrophilic dermatitis. The patient is having the patient is having skin lesions which are painful. The patient is having fever and it is edematous. So patient is having fever, it is painful, there is neutrophilic dermatitis. Right? Erythematous, edematous, dermatitis. Where is it seen? It is most commonly seen in Behçet's and also seen in some malignancies. This is called sweet syndrome. Another one syndrome which is associated with Behçet's that you must remember, this is called magic syndrome. What does magic stand for? It stands for mouth and genital ulcers with inflamed cartilage. Mouth and genital ulcer with inflamed cartilage. It's called magic syndrome. Mouth and genital ulcer with inflamed cartilage. Relapsing polychondritis with Behçet's disease. Right? Yes. So we have completed 4 steps. First, what did you do? First, we need to recognize whether the patient is having vasculitis. Right? Next, we have to rule out the secondary vasculitis. Causes of secondary vasculitis. Next, we have to study the pattern of vessels involved based on the symptom of presentation. Next, we need to remember the characteristic presentations of each of the primary vasculitis. I told you some salient points in each vasculitis that you must definitely remember. Okay, and these are all exam points. Okay, yes. So how do you diagnose these patients with vasculitis? You now think that the patient is having vasculitis, but you need to confirm that the patient is having vasculitis. For that, obviously, you need to do some tests, right? So what do we do? What are the first common tests? So first we do the CBC, right? In all patients, we do the CBC. I told you what all have we known so far? ESR will be elevated. When it is more than 100, it is usually common in giant cell arteritis or temporal arteritis. Right? ESR will usually be elevated in all inflammatory conditions, but in patients with giant cell arteritis, it will be more than 100. Right? Because it's an inflammatory condition and it's a chronic condition, what will happen? The patient will have anemia. And it is usually anemia of chronic disease. Right? In EGPA and HSP, what happens? The patient will have eosinophilia. Right? The patient will have eosinophilia. Right? So eosinophils will be elevated. So all these things we need to remember. Right? So EGPA, HSP, eosinophilia, mild anemia, ESR will be elevated. All this we can see in the complete blood count. Right? So moving on to the acute phase reactants, which is not very specific. Right? Highly sensitive C-reactive protein will be elevated in all inflammatory conditions. Right? Yes. So moving on to the chest X-ray or CT thorax. In this, what did we see? We saw two kinds. We saw already. One was when the patient is presenting a diffuse alveolar hemorrhage, they will have diffuse pulmonary infiltrates, right? That is diffuse alveolar hemorrhage. We saw some pulmonary cavities, nodular cavities, right? Cavitating nodules. That is seen in vaginous granulomatosis or granulomatous polyangiitis as it is called, right? You will have granulomatous polyangiitis. Nodular cavitating nodules will be there. X-ray of the paranasal sinuses, what will you have? You will have sinusitis, again in vaginous, right? So X-rays are also important. Imaging is also important. See, you saw the diffuse alveolar hemorrhage, right? And this you have a cavitating nodule. Here again you have a cavitating nodule, and the PNS you have sinusitis, right? Sinusitis is there. Yes. Next, moving on to the urine routine. Why do we need to check for the urine routine? We need to see that because of involvement of the renal pathology causing glomerulonephritis. So the patients can have proteinuria and hematuria can be there. Proteinuria and hematuria can be there. So we already know viral markers are very, very important. Hepatitis B, polyarteritis nodosa. Hepatitis C, essential mixed cryoglobulinemia. So now you understand why we came through the approach pattern, because you already know so many things and you're just consolidating here in this place. Something new that you will be learning under the investigations will be only the biopsy part. But otherwise, most of it you have already discussed earlier. So it will be very easy for you when you write an essay question as well as when you answer MCQs, because it is in a stepwise approach. Right? When you're solving an MCQ, you obviously need to solve the question, right? So you need to go in a stepwise manner. When you take this approach, then you will be able to identify the vasculitis very, very easily. So viral markers, hepatitis B, polyarteritis nodosa, hepatitis C, essential mixed cryoglobulinemia. So apart from this, what do we see? Immunoglobulin levels, IgA we saw in HSP, right? IgA we saw in HSP and IgA vasculitis. Hypergamma-globulinemia, it is a secondary cause, multiple myeloma. It can cause vasculitis. It is a secondary cause of vasculitis, multiple myeloma. Right? Elevated IgA levels, inox condyline purpura. Cryoglobulins, measurement of cryoglobulins, and you have in cryoglobulinemia. Then rheumatoid factor or ANA, you can see in rheumatoid arthritis or SLE. Rheumatoid arthritis or SLE. You need to rule out the secondary causes, right? Yes. Then moving on to the complement levels. Usually in immune complex mediated lesions, what happens? The complements are all involved in the pathology. So the peripheral complement levels will become lesser, especially seen in SLE patients. You will have low complements. You will see in cryoglobulinemia patients as well as HSP patients. These are all immune complex mediated lesions. In the immune complex mediated vasculitis, you will have complement levels which are reduced, right? It will be reduced. Again, ANCA, we know the P ANCA and the C ANCA. I told you P ANCA, C ANCA will be proteinase 3 and P ANCA will be myeloperoxidase. Right? You can measure these levels. You can measure the titers. Okay. And ANA I already told you for SLE. Then screening of SLE, collagen vascular disorders to suspect for secondary vasculitis. All this you need to get cleared. Right. So moving on to the specific investigation, which is biopsy. Right? You can either do a cutaneous biopsy or a renal biopsy to identify. Sometimes you may have to be doing a vessel biopsy also. In patients with giant cell arteritis, we will be forced to do a vessel biopsy. right? So renal biopsy, you can detect the glomerulonephritis. I told you one pattern, MPGN type 1 in cryoglobulinemia, right? Cryoglobulinemia. In HSP or IgA vasculitis, you have IgA nephropathy, right? IgA involvement, IgA deposition will be there, right? In post-immune vasculitis or ANCA-associated vasculitis, I told you will have rapidly progressing glomerulonephritis. In this, what will you see? You will see some crescents. You will have some crescents, right? So these are some important points that you need to remember in renal biopsy. HSP, IgA vasculitis. Then in cryoglobulinemia, you will have MPGN type 1. In RPGN, you can have some crescents. That is seen in post-immune vasculitis or ANCA-associated vasculitis, right? In skin biopsy, you need to find out there will be leukocytoclastis in the cutaneous vasculitis. What exactly is this leukocytoclastic? What do we mean by this term? What is it? It is the debris of neutrophils. Debris of neutrophils in the vessel wall. In the vessel wall. This is debris of neutrophils in the vessel wall. This is called leukocytoclastic vasculitis. There will be debris of neutrophils in the vessel wall. This is called leukocytoclastic vasculitis. In skin biopsy, you will have this leukocytoclastis in the cutaneous vasculitis in all the small vessels, right? So this is very, very important. Skin biopsy becomes very, very important. I told you renal biopsy and skin biopsy. Coming to the other biopsies which we do, temporal artery biopsy, I told you for giant cell arteritis, you have a nodular temporal artery which is less pulsation, where there will be less pulsation. So this is called temporal artery biopsy, giant cell arteritis. It will be a very stiff vessel. And sometimes in the part that you do, there may not be involvement because it is a very patchy involvement which is seen in temporal arteritis. Okay. So temporal artery biopsy. Next is pulmonary tissue biopsy. What we will do to show the small vessel vasculitis. Upper airway biopsies for vaginous vasculitis while doing for sinusitis. When the patient is having sinusitis, probably you can do an upper airway biopsy. Okay. So the main purpose of biopsy is to study the presence of leukocytoclastis. You can see immune complex deposition. You can see the characteristic pathology in the renal tissue. Also, the most important one, granulomas, right? You can also find out granulomas. Where do you find the granulomas? EGPA, GPA. EGPA and GPA, granulomatosis polyangiitis. Also in giant cell arteritis. Giant cell arteritis. Immunofluorescence, I told you, IgA deposition in IgA vasculitis or HSP vasculitis. So biopsy is very, very important and becomes very, very specific. Right? Temporal artery, sometimes it's a very patchy involvement. So the lesion where you have taken a sample, you may not get the diagnosis. Right? You must remember that point. Okay. So next is arteriography. This is again another specific test which we do. Right? So it helps us find out which lesion, which vessel is involved and to what extent. Right? So what do we actually see in this? We need to see whether the patient is having a stenotic lesion or an aneurysmal lesion. Aneurysmal lesion or stenotic lesion. Then only we can base the treatment. Right. So in patients with Takayasu arteritis, we can do an aortic angiography. In Takayasu arteritis, the patient can also have a renal angiography when you suspect renal artery stenosis. The patient can have severe renovascular hypertension. In that patient, you can have a renal artery involvement. So because it's a large vessel vasculitis. Cerebral angiography in patients with isolated CNS vasculitis. Renal angiography, you do it for PAN as well as polyarteritis nodosa as well as I told you Takayasu arteritis. Takayasu arteritis. Right. Will you do renal angiography for a patient with ANCA-associated vasculitis? Usually we won't do because it is a small vessel involvement. Okay, which will present with glomerulonephritis. Whereas in other components, in the medium or small, large vessel vasculitis, the patient will have stenotic lesions, renal artery stenosis. That's when you need a renal angiography, right? Coronary angiography, you saw there will be aneurysms in Kawasaki's disease. Lower limb angiography for Burgess disease or thromboangiitis obliterans, right? All these angiographies, arteriographies are very, very important, right? So now we come to the last step, almost to the end. So we have now diagnosed the patient and now we are going to treat the patient. So treatment is fairly simple. What is the mainstay of treatment in these patients? The mainstay will be that you have to immunosuppress the patient. So how we immunosuppress the patient is the next step. But what are we going to do? We are going to immunosuppress the patient, right? Because the inflammatory activity is more, you need to immunosuppress the patient. How do you do this? You give glucocorticoids, right? You give glucocorticoids. Along with that, what will you give? You will give cyclophosphamide, methotrexate you can give azathioprine based on the patient and the condition, right? You can also give cyclosporin, rituximab, anti-TNF therapy, infliximab, adalimumab, etanercept. All these can also be added along with the glucocorticoids, right? You can add along with all this along with the glucocorticoids. Okay. Yes. So glucocorticoids are the mainstay. So the choice of therapy usually depends on the severity of organ damage and what are the vessel involvement, the extent of multisystem involvement as well as the organ damage and which vessels are involved. Is it the renal vessels or the ocular vessels or the coronary vessels which are involved? Based on this, we are going to guide the treatment, right? So how do we give the steroids? Usually in severe cases, we actually pulse steroids. IV steroids will give IV steroids, which is called pulsing. IV pulsing steroids followed by oral glucocorticoids, oral steroids, right? That's how you give. Along with that, you can add a second line agent like azathioprine or methotrexate or cyclosporin or cyclophosphamide based on the patient's condition, right? But when the patient is having very severe complications, along with this pulsing, you must definitely give the patient cyclophosphamide, right? You must give the patient cyclophosphamide. Then what happens in PAN? I told you the patient is having poor prognosis because the patient is not responding to steroids. The patient is not responding to steroids, right? But in the patients having mild disease, only glucocorticoids alone will be sufficient. You initially give a high dose and then you taper gradually, right? Along with this, you must also, what should you do? The secondary causes should be identified and treated. If the patient is having a hepatitis B infection or hepatitis C infection, you need to give the antiviral agents. Once the antiviral agents are given, the patient symptoms will drastically reduce. So antiviral therapy is very, very important. Then aspirin therapy. Aspirin is very, very important. Along with IVIG, you given Kawasaki disease. What do you do? IVIG plus aspirin. That is what given in Kawasaki disease. And also in giant cell arteritis because the pain is too much, right? So you give aspirin along with IVIG. Aspirin along with IVIG, you give it for Kawasaki disease patients. So even intravenous immunoglobulin will actually prevent the coronary aneurysms in Kawasaki's. It will prevent the coronary aneurysms in Kawasaki's. So we are giving so many drugs. So what should you do for the patient? You need to monitor this at regular intervals. You need to check the liver function test. You need to see the counts because all these are immunosuppressants. What will they do? They will reduce the bone marrow production. So the bone marrow will also become suppressed. So from time to time, you need to see whether the bone marrow is reacting properly, whether the cells are being produced effectively, and also whether the LFTs are maintained, whether renal functions are improving. All these things you need to identify and you need to maintain, right? Apart from this, you are giving glucocorticoids for a longer duration. Usually these vasculitis requires treatment for a longer period of time and they also have a relapsing course, right? Once you treat, it's done. It's not like that, right? It keeps on coming back again and again. So what happens? You will have to give more and more steroids for the patient. So when you keep giving more steroids for the patient, you need to monitor the steroid side effects of the patient, right? So what are the steroid side effects of the patient? The patient can have osteoporosis. The patient can have growth retardation. The patient can have bone marrow suppression, right? Cyclophosphamide, when you give the patient can have cystitis, right? When you give methotrexate, the patient can have hepatic toxicity. They can have renal toxicity also. All these side effects that you need to remember, you need to keep in mind so that you have to prevent the toxicities. You must give steroids for as much as shorter duration as possible. You reduce the immunosuppression to the least minimum dose possible and try to maintain the patient, right? And you try to maintain the patient. Regular monitoring of blood counts, renal and hepatic functions are very, 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 very important. You must ask the patient to come regularly for a checkup. You need to educate the patient, right? You have to make them aware of the disease process. Make them aware of the natural course of the disease, how it treats, how it reacts to the treatment. You need to keep updating the patient on a regular basis so that the patient is more aware and comes forward to you for treatment very regularly and does not miss on all the side effects. Okay, all these things can be prevented, right? The long-term toxicities can be very easily prevented. The side effects can be prevented. So you need to keep this in mind and approach a patient with vasculitis with lot of care and lot of, very diligently you should actually treat the patient so that their quality of life is not affected on the long run, right? Yes. So let us now summarize the steps. First is you're recognizing vasculitis. Which patient can have vasculitis? You're recognizing that. Next, you're ruling out the secondary causes of vasculitis, infection, drugs, malignancies, malignancies, all that we saw, right? Next is this pattern of vessels involved, whether it is large vessel, medium vessel, or small vessel, which vascular involvement is there. Next, remembering the characteristic pattern and symptoms in each vasculitis. Like I told you, giant cell arteritis, temporal artery will be visible, palpable. Okay, it is a granulomatous inflammation, right? It is also called temporal arteritis. Next, moving on to Kawasaki, you will have a strawberry tongue, right? Behçets, you will have oral genital, and mucosal ulcers will be there. Recurrent ulcers will be there. The patient can have uveitis also. In polyarteritis nodosa, steroid refractory, you will have microaneurysms, right? All these are some very, very important points. Cryoglobulinemia, hepatitis C infection, polyarteritis nodosa, hepatitis B infection, right? The other primary vasculitis, you must remember all these things in detail so that you don't remember. You will definitely have some key points in the question in the MCQ, based on which whatever I have told you, all the salient features will be identified as key points, right? So you must keep that in mind so that you will be able to identify the disease very easily. Once you identify the disease, you will be able to tell the diagnosis as well as the management. Biopsy, you must remember very, very well. Granulomas, where you see granulomas, where you will see IgA deposition. Glomerulonephritis, what are the patterns that you can find? All these are important MCQ questions. Then, how do you diagnose and what are the principles of treatment, right? Principles of treatment. So here we complete this topic. I thank you all for joining. I hope it was a very valuable discussion and it's a very concise and interesting discussion. I hope it is useful for all of you, right? Thank you so much for joining.